Hello, everybody, and good afternoon. Thank you so much for taking time out of your busy Idweek conference to come and spend some time with us. My name is David Hong. I am Vice President of Medical Affairs and Clinical Development at Karius. And what we're going to do over the next 35 minutes or so is talk about the Karius Test, which is a next-generation sequencing test for pathogen detection. We have a series of 3 fantastic speakers who are going to talk about their experience with using the Karius Test, both as a research tool and also clinically. And we've titled this Liquid Biopsy for Infectious Disease. I know it might be an unusual term for you folks, but I'm going to walk through exactly what that means. And so thank you again for coming, and let's go and get started. So when we put together the Karius Test, really the problems that we were trying to solve, if I can get this clicker to work. The clicker is not working. Here we go. It's not working. Is the challenge of diagnostics. So I'm a pediatric infectious disease physician by training. And one of the challenges that we have, particularly with the types of patients that we see sometimes in the children's hospital, and I know that many of you see, is that oftentimes for the clinical syndromes that we care for, the current diagnostics can be limiting. And so I put up 2 examples there. In pneumonia patients, we're dealing oftentimes with an unknown pathogen in about 60% of patients, and these are data from the CDC EPIC study. And then also in sepsis, many times blood cultures are negative, and we're dealing with unknown pathogens in anywhere between 30 to 50% of those patients. The other issue is that many times with deep infections, we have to sample deeply in order to get appropriate material for culture or to identify that pathogen. Now, with some of the medically fragile patients that we take care of, this can be really challenging to get an appropriate sample and to put our patients through that procedure. All right. So what we do in order to solve this is that we take advantage of the fact that infecting microbes leave traces of genomic DNA in blood, right? And so as these organisms are dead and dying, they'll leave traces of their genomic DNA in plasma, and this is what we take advantage of in order to use our diagnostic. And so this approach has been used in other applications, like looking at fetal DNA in pregnant individuals to diagnose trisomies and other fetal aneuploidies, all the way through transplant monitoring and tumor DNA or circulating tumor DNA. This is what the oncologists have called liquid biopsy, where you can take a plasma sample and non-invasively detect solid tumors without having to do a biopsy. And we think of our technology as a cousin of that technology. In fact, as a liquid biopsy for infectious disease, being able to identify both bloodstream infections and deep-seated infections with a single non-invasive test. So what this graph shows is that over the last year or so, these are some highlights of pathogens that we have detected using our test clinically. And not only can you see the list of organisms that we've identified across virus, bacteria, fungi, unculturable organisms, but also the location of that infection, all with a non-invasive plasma test. And our speakers will go into their experience using this kind of approach in that manner. This clicker is not working very well. So the test itself identifies over 1,000 different pathogens across bacteria, both cultural bacteria and unculturable, DNA viruses, and then you can see the list of eukaryotic pathogens, both yeast and molds, Aspergillus, non-Aspergillus molds, and also other difficult to diagnose eukaryotic pathogens listed there. You can find the full list of the pathogens on our website. And so the way it works, just really briefly, 5 mils of blood in a plasma preparation tube. We can use smaller volumes in pediatrics, so please talk to us about that. And that sample is then brought to our labs here in Redwood City in the Bay Area. And after performing next-generation sequencing, we align those sequences across our proprietary database, curated database of over 1,000 different pathogens. And then we identify and quantitate those, or quantify those pathogens and release that in a report. And typically we return that result next day from the time that we receive that sample. And so the speakers today range from a wide range of applications of the test. We're going to start with Dr. Bill Muller talking about our collaboration in invasive fungal infections in pediatrics, and then move to Dr. Chris Cooper from Florida Hospital talking about his clinical experience with the Karius test over the last year. And then lastly, Dr. Rand from University of Florida will talk about a case of acute encephalitis where he used the Karius test. And so we're going to start things off with Dr. Muller. And so Dr. Muller is an associate professor of pediatric infectious disease at Lurie Children's Hospital, Northwestern University. You have to point it at it. Yeah, I know.
Got it. All right, thanks, Dave. Is this loud enough? Okay. Thanks, Dave. I'm going to talk about a study that we did in collaboration with Karius. In collaboration with Karius. How is it in the back? Is it okay? More? Okay. This is a study we did at Lurie Children's Hospital in Chicago in collaboration with Karius. And it was intended to investigate the use of this test in pediatric patients at risk for invasive fungal infection. So I don't know if this audience really needs a whole lot of background in diagnosis of invasive fungal infection. Of course, it's our immunosuppressed patients that are most at risk for this type of infection. And this includes our oncology patients, our stem and solid organ transplant patients, and in a pediatric setting, our patients with primary immune deficiencies are also at risk. And these infections have high morbidity and mortality and often require prolonged treatment, often for several months. Diagnosis is often challenging, and as Dave highlighted, often involves either invasive methods where we have to actually go in and get a sample, or indirect testing in the right clinical context, such as use of imaging where you see characteristic findings like nodular disease, or indirect tests of the blood like beta-D-glucan testing or galactomannan testing, which in pediatrics don't really have well-defined performance characteristics. So we were interested in investigating metagenomic next-generation sequencing as a potential additional assay that we could use to try to diagnose invasive fungal infection in our pediatric population. And so we undertook a study in which we collected samples from the patients that we considered to be at highest risk for invasive fungal infection, basically using as criteria for enrolling these patients the same criteria that we would use to implement empiric antifungal treatment therapy. So these would be patients who have either hematologic diseases or hematologic cancers, solid tumors, stem cell transplants, and had either one or both of prolonged febrile neutropenia, where they had fever for more than 96 hours despite broad-spectrum antibacterial therapy, or they had findings that would be consistent with the diagnosis of an invasive or of a new fungal infection, including abnormal imaging, recurrent fevers in the setting of neutropenia, a characteristic skin rash, or if a fungus was identified in what was potentially a non-sterile site, such as a skin lesion or in urine. We did not enroll patients if they had been treated for more than 3 days with a treatment dose of antifungals, but if they were receiving prophylactic antifungals, they were actually eligible to be enrolled. And then we collected plasma samples at enrollment and actually wanted to study also the performance characteristics over time, where we collected samples 1 and 2 months after they were enrolled. I'm not going to talk about that data, except to say right now that we did not find positives in the repeat samples. During the analysis of results, so after the patients were enrolled, we then went back and compared the criteria of the patient's clinical characteristics with the EORTC mycosis study group criteria to determine whether or not patients would be classified as proven, probable, or possible invasive fungal infection, and compared those results from normal clinical tests to the results from the Karius testing. Dave already went over the assay and how it works, so I'm not going to go through it in a lot of detail, other than to say that in the clinical setting, which we also use this test in our hospital for, the sample results can come back within about 24 hours. For this particular assay, these results were not available to the clinicians in real time, so they were sent off and batch processed and then compared later to the clinical characteristics of the patients. So we had 40 patients that we enrolled in this study, and they ranged in age from 1 to 24 with a mean age of 11. There was a male predominance, so about 65% of the patients were male. And their underlying diagnosis, as is expected in the pediatric setting, was largely hematologic cancers. So more than half of patients had either leukemia or lymphoma. But there were a scattered amount of patients who had other underlying diagnoses that put them at risk for invasive fungal infection. Most of our patients were enrolled because of prolonged febrile neutropenia, but there were also some patients who were enrolled for some of the other reasons, including recurrent febrile neutropenia or abnormal imaging findings. And when we classified these patients after they were enrolled and their testing was sent, we identified that 6 of those 40 patients had proven invasive fungal infection based on the EORTC MSG criteria. 1 had probable invasive fungal infection, 11 had possible invasive fungal infection, and 22 did not meet criteria but were still considered to be at high risk or suspected of having invasive fungal infection. So I'm going to go through those different categories and how those patients compared with their clinical assays versus the Karius test. So this slide shows the first 3 of the 6 patients who had proven infection. And you can see in the second column that the Karius testing was able to identify 3 different genera of fungus that were also identified by standard clinical assays. And those clinical assays involved localization of these fungi from sites from numerous different sites within the patient. So the first patient had invasive pulmonary fungal infection with Aspergillus, which was identified in the plasma by Karius next-generation sequencing. The second patient had a positive blood culture that was consistent with disseminated candidal infection, which was also identified by the Karius testing. And the third patient actually had a skin lesion that was ultimately culture positive for Rhizopus, and the Karius testing was able to identify Rhizopus delamar, suggesting to us that there was at least enough angioinvasion of this fungus for the DNA to get into the bloodstream for this test to become positive. For the next 3 patients with proven infection, the first one also had the infection proven by standard microbiologic techniques. This patient had a pancreatic cyst abscess, which was positive for both Candida and for Salmonella, and Karius testing picked up both of those organisms in the plasma. The next 2 patients actually had discordant results between Karius testing and the clinical testing that was done. The first of these is a patient who had ALL, and this is a patient who had Pneumocystis jirovecii identified by Karius testing. Now, the interesting thing about this patient is he also had a positive beta-D-glucan test, which is consistent with pneumocystis. And this patient also received treatment for pneumocystis empirically after admitting that he had not been taking his prophylactic Bactrim therapy for an extended period of time. On day 27 of the 28-day culture of his lung biopsy, he grew Aspergillus, and so he actually eventually wound up being treated for both, although Karius testing did not identify Aspergillus. The last of the proven invasive fungal infection patients was a patient who had a superficial infection that skin biopsy demonstrated Rhizopus oryzae by culture and by 18S ribosomal DNA sequencing. This patient had negative Karius testing, which we suspect was potentially due to the lack of angioinvasion, that this infection was caught early enough so that the DNA did not get into the bloodstream at high enough levels for it to be detected. There was 1 patient with probable invasive fungal infection by the EORTC MSG criteria. This patient actually was diagnosed with pneumocystis pneumonia. This patient had a BAL that was negative for pneumocystis, did receive treatment in the hospital while awaiting those results directed against pneumocystis, and ultimately was discharged with the diagnosis of viral pneumonia. So it's possible that the Karius test is a little overly sensitive for pneumocystis, or that the short course of treatment may have actually resolved his symptoms. I'm just going to summarize the patients with possible invasive fungal infection and with suspected invasive fungal infection as a group. There were 11 patients with possible invasive fungal infection. 9 of these were ultimately treated for invasive fungal infection, even though clinical testing did not demonstrate a specific organism. And of these patients, 5 of them had negative Karius testing, which raises the question of whether or not a negative test could allow us to avoid prolonging antifungal exposure in some of our patients. We also identified potential alternative sources of fever in 4 other patients, which are listed here, including CMV, which in some of our patients was also identified by PCR in the blood. I'm also going to note that some patients had polymicrobial results reported by Karius testing, 2 in this case. These are often interpreted by us to mean that there is mucosal translocation of bacteria from a compromised GI tract, although sometimes these are questioned, and we can talk about that a little bit more in the discussion. The patients who did not meet criteria for invasive fungal infection was the largest group. There were 22 of them. 12 of them ultimately did get treated for invasive fungal infection, again, despite the absence of a microbiologic diagnosis. 6 of these patients had negative Karius testing. 12 of them had potential alternative sources of fever. 1 of them had Candida garbata. And I'll note that this patient actually received empiric treatment in the hospital for fungal infection that would have treated as candida for a course of 7 days. It was ultimately discontinued. It was discharged without further recurrence. It's possible that this was a true pathogen in this particular setting. And I'll also note that this was the only one of 33 patients who did not have proven disease, or proven or probable disease, who had a positive Karius test for a fungus. So I'm going to summarize our study that we were able to demonstrate that this test can provide positive results for invasive fungal infection in high-risk patients, potentially avoiding biopsy in some of these patients. In our case, 4 out of 6 with proven invasive fungal infection by EORTC criteria. That I noted that prolonged antifungal courses are common, and there's the potential for, if this testing can be shown, to have good negative predictive value for avoiding prolonged antifungal exposure in a lot of our patients. I mentioned 21 out of 33 high-risk patients without proven or probable disease were treated with a prolonged course of antifungals. I did not really highlight in a lot of detail, but this testing can identify other alternative sources of fever in these patients, and you'll hear some more cases of that in our next speakers. We also identified some patients who had presumed mucosal translocation, and so that's something to keep in mind when you get polymicrobial results from this test. We don't know whether or not this represents impaired barrier function or true disease, but we suspect the former. Obviously, there's limitations to any single center study. There's only a limited number of patients. We can't draw firm conclusions about performance characteristics like sensitivity, specificity, positive and negative predictive value with such a small sample. But we hope that this provides data to suggest that such studies would be possible and would be welcome to try to improve the diagnosis of these patients using this test. We also highlight these polymicrobial tests, and I think this calls to mind that we do require some expertise to interpret this, and this keeps infectious diseases physicians important in terms of interpreting these results. And I mentioned 2 patients that had positive pneumocystis testing, which was unclear if that was the source of disease in those patients. And so I think we need a little bit more data to prove whether or not that is an important finding with this test. So I think I called attention to some of the future tests or future studies that we can do with this technology in this population of patients, which would also raise questions in other populations of patients who are at risk for difficult to diagnose infections. And hopefully we'll have some discussion at the end about how this testing might be used in your patients. So I'd just like to thank the people who participated in this study for us and Karius for supporting this study. And we can talk about questions at the end after everybody else has had a chance to talk about their cases.
Thanks. Well, thanks, Bill. As Dr. Muller mentioned, we're going to have questions at the end, so please hold on to your questions. Our next speaker is Dr. Chris Cooper. Dr. Cooper is in private practice, infectious disease in Orlando, Florida, and he's going to talk about the clinical experience, or his clinical experience with the tests at his hospital. Just kind of point.
Is it this one?
Yeah.
All right, David, thank you, and I'd like to thank Karius for asking me to come and speak to you guys today. There we go. So to give you an idea of where I work at Florida Hospital, and I mainly specialize in infectious disease in the immunosuppressed population, mainly heart, lung, and endovascular infections. And that's in a way kind of how over the past year our relationship with Karius has developed since we met in IDSA last year. The main areas where I've been utilizing has been in pneumonias, ICU cases, and as well as our cardiovascular infections, mainly our native and prosthetic valve endocarditis that are obviously culture negative. So what I'm going to do is just kind of go over a couple cases that to me kind of really highlight how useful the Karius test has been for us in our institution, and also for what sort of surprises it has shown us. So the first case is going to be a 65-year-old male who was a bilateral lung transplant for idiopathic pulmonary fibrosis. He got readmitted. He had a very prolonged hospitalization. He was in the hospital for over 6 months after his transplant. Various pneumonias, bacterial pathogens were isolated. But it came to the point where he kept having increased secretions, bronch after bronch, negative, culture negative. Couldn't really figure out what was going on with him. Ended up getting transferred to the ICU, got intubated, eventually trached. This kind of gives you an idea of what his CTs were looking. we started on broad spectrum antibiotics, still no improvement. Again, multiple bronchoscopies, looking for a result. Could not figure out what was going on. Continued to worsen, fever, increased LFTs, clinical decline. So at that point, I decided, well, I'm going to go ahead and send Karius on this test, on this case here. And lo and behold, the patient popped up with herpes simplex virus 1. And this was a big surprise to us. It wasn't something that we were expecting or even were considering. And going back through the pre-transplant serologies, he was certainly positive for HSV1 on his IgG, but certainly, over 6 months out, this wasn't something that we had thought of at the time to be a causative pathogen. So we went ahead and obviously put him on appropriate antiviral therapy, and he did have some improvement. We did also do some confirmatory testing as well. On the next bronch that was done, HSV PCR was done, and it was positive. We also did it on the bloodstream, and it was also positive at that point too. So the patient did improve on the acyclovir, and I think that the take-home point on this one is that it identified an unsuspected pathogen for us. Okay, and he was presenting very much like a bacterial pneumonia. But when it was all said and done, it turned up to be a disseminated HSV infection. So that was one case. Another good case that we had was one of our 52-year-old with HIV, who was very well controlled, and we do HIV heart transplants at our institution. So he underwent a heart transplant, and about 7 months later, he presented to our institution with cough, chills, and hemoptysis and fever. Now his HIV is very well controlled. His CD4 counts over 800, and when he did present, the ER did their appropriate workup, and of course he was flu B positive. But due to the severity of results, something told me just go ahead and let's get a CAT scan on this guy, and sure enough, we had a right upper lobe mass. Now at the time we went ahead and sent the Karius, but also this was Karius was new to us when this patient presented. So we weren't really sure how it was going to work out. So we went ahead and did a Karius, and we did a transbronchial biopsy. And by the next day, we got the call that we had branching rods on the biopsy. So that kind of certainly made us suspicious for a nocardia infection. 16S was also sent on that biopsy that came back as unable to identify an organism, and the cultures were, of course, pending. So once we had that, this is kind of gives you an idea of what his CT looked like. Karius was sent off, and by that 48-hour mark, we came back with nocardia knee-way. So that was subsequently confirmed, on our culture, but it came back about 7 days later. So once we got those results, we started to narrow down our antibiotic coverage. And again, the transbronchial biopsy did come back with the nocardia. So for me, this kind of illustrated, this was one of the first times where I was thinking in my heart transplant population, when we have these sort of lung masses and these suspected infections, how we could start utilizing Karius a non-invasive rapid identification manner. And everyone knows that sometimes nocardia is a little bit hard to grow, hard to identify. It could take a couple of weeks to come up, so it can kind of fool you. But fortunately, in this case, it not only did it grow, but also came up on the Karius. So this was a woman. The next case was a lady that just got discharged from the hospital last week. This is a 35-year-old that presented with culture-negative prosthetic mitral valve endocarditis. Now, she had a known history of APA syndrome, was on warfarin. She had a known history of endocarditis with an unknown pathogen back in 2014, and unknown just because we couldn't get the records. She had an MVR at that time, and then also again had further strokes in 2016. She presented to our institution with an acute stroke, also in heart and renal failure. On echo, she had a 1 by 2.7 centimeter vegetation on her prosthetic mitral valve. Now, at the other institution where she came from, as well as our institution, all the cultures were negative. My partner over the weekend, who started the workup, did a very broad serological workup, started looking for our usual culture negative workup. Antibiotics were started, vancomycin, ceftriaxone. And the next day, though, I came on board, and I thought this would be a very good case for Karius. So I went ahead and sent it off. And I got a call that, hey, listen, we have Bartonella detected on the Karius testing. So changed the antibiotics to more appropriate antibiotics. We had to use doxine, rifampin, couldn't really use gent because of her renal function. And she ended up going for surgical debridement and had her MVR. Now, subsequent labs also came back, showed a Bartonella IgM that was negative, but the Bartonella IgG was positive at over 1,024. So to me, the take-home point on this case was sort of the utility of the Karius testing, especially in our culture negative arena. And in our institution, prior to Karius, we had only seen about one case of confirmed Bartonella in about the last 7 or 8 years. And in the last 5 months, we've had 2 cases now, both diagnosed off of Karius. So it was, to me, a little bit an important point, seeing how this test is going to be utilized for us in our culture negative endocarditis realm. So where do I see some of the future of this non-invasive NGS testing? In our institution, we're sort of moving this a little bit more and more first line, not waiting for a week, 2 weeks, 3 weeks, trying to chase fevers of unknown origin. We're utilizing this a little bit more upfront, and it's not uncommon in our lung, especially in our lung transplant populations, where as soon as they hit the door, my lung transplant doc is getting this test ordered. So we found it very, very useful in even for some first line applications. For me, also avoidance of invasive procedures. Anytime we can avoid a bronchoscopy and a transbronchial biopsy, that's of course always going to be very beneficial to our patients. And then more and more recently, as we've gotten more use or more experience with this test, we've been exploring the value of a negative test. Looking at things that kind of look and act like infectious disease, but turns up was bleomycin lung injury. So we were able to sort of, de-escalate antibiotics and make that diagnosis and feel relatively comfortable putting the clinical picture together that once we had a negative NGS, looking at everything else, we could take off those antibiotics and de-escalate as needed. So we're more and more utilizing Karius for some of even the negative testing value that it brings to us. So, and at that point, we'll do our questions for the end. And
yeah.
Thank you.
Thank you, Chris. So I hope that gives you an idea of Dr. Cooper, experienced infectious disease physician with a busy practice, how the test has been used over the last year. We're going to end with Dr. Rand, who's a professor of pathology medicine at the University of Florida, who's going to present a case that kind of explores the power or the limits of the technology in particularly diagnostic challenging quick cases. Thanks. Dr. Rand.
Okay, well, thank you, David, and thank everyone. Thank you all for coming. Here are some of our interesting experience with this potentially exciting new technology. So I'm going to try to figure out how the.
I think you have to aim it kind of. Yeah.
Okay. First lesson. Okay, so this was a 51-year-old man who presented to our emergency department with basically altered mental status. He had night sweats, he had fever, headache, left-sided weakness, confusion, incoordination, and seizures. And the seizures had actually started about 6 months earlier, but hadn't been a problem, except they'd gotten more frequent in the past 2 weeks. And he even went to an outside hospital about a week before coming to our institution, where we had a CT that was negative. His past history was unique, I think, in some ways. Substance abuse. He had heavy alcohol use. He worked as a mason. He traveled around the state of Florida. He sort of stayed in work camp-like environments with communal showers. At home, he lived on a farm. They had multiple types of pets and farm animals, and he recently lost an entire litter of puppies. All died of an unknown cause. Of note, he had a history of over the past 6 months of extracting every one of his teeth with himself with a pair of pliers. And we're not quite sure why he resorted to that, but whether that became the portal of entry, we don't know. He was alert but confused, not oriented to person, place, time, was febrile. Vital signs were reasonably okay. The left-sided weakness was noted. This was his initial MRI a couple of days, 24 to 36 hours after presentation, showing multiple areas of the cerebellum, parietal and occipital and frontal lobes with abscess formation, as you can see in the frontal lobe image there. And his spinal fluid did have high white count, 330. It had a high protein, but a normal glucose. And then, of note, the white cells were predominantly lymphocytes. He was started on vancomycin. I think you've all heard that one. Plus metronidazole, because good choice. All of the sort of standard cultures and PCRs that you would do, I won't read the whole list, but the common ones were all negative. And we were kind of left scratching our heads as he was not improving on current therapy. So at this point, would anybody like to volunteer a diagnosis? You'll have to shout. Okay, well, we weren't shouting either, so. He was intubated, moved to the ICU, and they went to a brain biopsy, which you have to give them credit for was the right thing to do, given that we weren't figuring this out non-invasively. And the frozen on that was no tumor, but the real guilty party, I think, will now stand up, because we did send the Karius at that point, and it came back with Biopsy mandrillaris, which is a known cause of granulomatous amoebic encephalitis, along with Naegleria and acanthamoeba, and the one that none of us can remember. Whoops. On the biopsy, once the pathologists knew about the diagnosis, they were quick to find it. And, the arrows point to a couple of amoebae in the brain parenchyma. There's also extensive necrosis and vasculitis. He was really immediately started, and I have to give everybody credit on this. David Hom called me and said, "This is what you've got." And after I picked myself up, I called the ID clinician who was being consulted on this, and they got him on these anti-amoebic agents really quite rapidly. But unfortunately, his disease progressed, and he expired about 4 to 5 days after we made the diagnosis. So retrospectively, spinal fluid and the formalin fixed tissue from the brain biopsy were sent to CDC, who confirmed the diagnosis of Biopsy mandrillaris with PCR on the spinal fluid and immunohistochemistry on the brain biopsy. So Biopsy is one of the free-living amoebae that are known to cause granulomatous amoebic encephalitis. It's believed to enter the body through the skin, primarily cuts or wounds, but potentially also dust that can be inhaled. And if he had lots of open tooth sockets, maybe he possibly could have acquired it that way. Skin lesions are common in this entity, and he did have a skin lesion, which unfortunately we tried to get biopsied, but in the heat of battle, it unfortunately didn't get done. These skin lesions can last for weeks or months, or they can be much more rapid in their presentation and course. In terms of the encephalopathy or encephalitis, it's generally fairly rapid, progressive, and fatal. There have only, I think, been 6 or 7 cases as of 2017 that have survived with treatment. And part of the reason is obvious. It's hard to think of amoebae as causing brain disease like this case, and availability of a specific PCR is essentially non-existent. So Karius testing really was a big help in this case. And there have been about 200 US cases. And the CDC, and we all think that it's underdiagnosed, and there's probably a lot more. So in summary, we've presented a case of Balamuthia mandrillaris, granulomatous encephalitis. Rapid non-invasive diagnosis was made through the detection of cell-free DNA in plasma by next-gen sequencing and confirmed by specific PCR in the spinal fluid and specific IHC in the brain biopsy. And unbiased next-gen sequencing for pathogen detection really can help us deal with the kinds of problem cases that we see in our clinical practice. It requires clinical judgment, and I think personally the hardest thing to do is to figure out early in the course of a patient, whatever the underlying cause is, and get the test early enough to make a difference. So with that, I'll leave you to ponder your own practice and cases you've seen, and thank you all very much.
Well, thank you, Ken. We have time for some questions. What I'm going to do is just leave you with this. So we really consider our test as a liquid biopsy for infectious disease, both because of its broad detection and non-invasive detection of these pathogens. And I think you heard a lot of the speakers talk about the speed at which we're able to return this. So we typically return a result on the next day that we return that sample, because we know how important it is for you as a clinician to get that information to make a difference for your patients. And you heard of some of the applications that some of the physicians talked about. We really think about both culture-negative sepsis syndromes or culture-negative infections, as well as infections in immunocompromised patients. And so I'm going to pause here, and we can take some questions. And we're going to experiment with running the microphone around. So.
Yes. Yes, speak.
Hi, can you maybe describe some cases where your test has been equivocal, or you don't, what are some of the problems potentially with the test as far as making a diagnosis?
Yeah, I can handle that one. So there are times when we will identify more than one pathogen. So the way that the test works is that we identify those organisms that are above a predetermined statistical threshold. And sometimes you will have 2 or 3 pathogens that are identified. Now, one of the things that we do now is that we give you a quantity of each of those pathogens that are detected, so that can help to contextualize each of those infections. But I think Dr. Muller mentioned in his study, there were instances where due to low-level translocation of bacterial DNA, we would see multiple pathogens, and we're really starting to understand what those patterns might mean so that we can better contextualize those results.
I know that infants become colonized or get infected first time with Pseudomonas extremely early in life, and so that it may circulate a lot. And I'm wondering if you have other evidence that pneumocystis may be picked up occasionally when it's not the pathogen.
So just to clarify, you're talking about Pseudomonas and then also pneumocystis? Pneumocystis. Okay, yeah. So Dr. Muller in his study brought up the fact that pneumocystis was detected a few times, and I think as we're understanding a little bit more about pneumocystis, particularly when we look at some of the respiratory PCR data, we see that pneumocystis is present even in immunocompetent patients or when they're not ill. What we're finding is that we oftentimes do, or not oftentimes, but when we do detect pneumocystis, this is where that quantitative number is really starting to help us. With low levels of pneumocystis, it may not be necessarily that causal driving pathogen, whereas for very high quantities of pneumocystis, it's less ambiguous. And to that point, we're really understanding what these numbers mean as we're gathering more experience with the test.
Thank you. Can you speak to the negative predictive value of a negative NGS?
Go for it.
So the question was about the negative predictive value of the test. So when you look for all of these pathogens simultaneously, there are times when we'll have a negative test. Many times we will have a negative test. Now, we don't make any claims around the negative predictive value of the test. We haven't done the studies necessary to show that. But I think what Dr. Cooper demonstrated was, in the heat of battle, when you're trying to figure out, is this infectious syndrome versus a non-infectious syndrome, this is another piece of data that I think clinicians can use in the context of all the clinical information that's available. But just as a diagnostic test, when we think about PPV, MPV, we haven't made any claims around the negative predictive value. All right. Any other questions? Oh, okay.
You mentioned that it can be that the appropriate sample is plasma, but can't be used with other specimen types.
So the question was around other specimen types. So currently we only test plasma, and specifically cell-free plasma. We find that just given the fact that pathogen DNA can be shed into plasma from all these different locations, we're really focusing on plasma. I know there are other applications of NGS that have looked at other tissue types, but for now we're focusing on plasma. We are in the future exploring other potential tissue types, but plasma is where we're starting. Okay. You know what? In the interest of time, I just want to highlight a couple of things that are going on at Idweek. Anyway, we have a number of other presentations that are going, both posters today and on Saturday. Also, there will be an oral presentation with our collaborators from St. Jude's. This is data that from a study that we call the PredSeq study, using our test to predict bloodstream infections in high-risk leukemic patients. These patients were serially sampled as they became neutropenic on chemotherapy. And what we're doing is we're trying to use the test if we can identify bloodstream infections before blood cultures are positive. At this point, I really want to thank the time for our speakers, Dr. Muller, Dr. Cooper, Dr. Rand. So if we can give them another round of applause.
Applaud that.
And please come and talk to us. We're at booth 419. A number of my team from the company are here. They're scattered around the outside. Look for people with the Karius badge. We'd love to talk to you about how this kind of technology can be really used for your patients, really help your patients. So thank you for your time. Hope you have a great rest of the conference.